non-cirrhotic portal hypertension. It's a group of liver disorders of vascular origin leading to portal hypertension with near normal HVPG. EHPVO is in childhood, which is extrahepatic portal vein obstruction, and NCPF is in young adults, middle-aged women. Both have preserved liver function. Portal hypertension is a clinical syndrome defined by portal venous pressure gradient between portal vein and IVC of more than 5 millimeters. In cirrhotics causing portal hypertension, there's increased HVPG, but non-cirrhotics, the HVPG is normal or slightly elevated or reduced. NCPF is also called hepatoportal sclerosis or idiopathic hypertension, portal hypertension, or obliterative venopathy. It's a disorder of unknown etiology characterized by portal hypertension, splenomegaly plus or minus hypersplenism, normal liver function, patent hepatic and portal veins. According to APASL, 10 to 30% of varices can be attributed to this. Causes of NCPH: prehepatic, hepatic, and posthepatic. Prehepatic, we have extrahepatic portal vein obstruction, portal vein thrombus, splenic vein thrombus, massive splenomegaly as in infiltrative disorders, myeloproliferative disorders. Hepatic causes would be pre-sinusoidal, sinusoidal, and post-sinusoidal. Pre-sinusoidal would be developmental abnormalities like polycystic liver disease, hereditary hemorrhagic telangiectasia, AV fistulae, and congenital hepatic fibrosis. Biliary disease like PBC, PSC, autoimmune cholangiopathy, granulomatous diseases like sarcoid, and even schistosomiasis. The reaction that schistosomiasis causes is granulomatous inflammation. Pileosis, hepatis, NCPF. Sinusoidal causes would be sinusoidal fibrosis, sinusoidal infiltration. In fibrosis, you have alcoholic hepatitis, drugs like methotrexate, amiodarone, metabolic causes like NASH, and inflammations like viral hepatitis. Sinusoidal infiltration would be seen in mastocytosis, amyloidosis. And then we have the post-sinusoidal, in which there is veno-occlusive disease, like in radiation, toxins like pyrrolizidine alkaloids, drugs like gemtuzumab and azathioprine. Then we have post-hepatic causes, which are IVC obstruction, like in a web, tumor, thrombus, tricuspid regurgitation, constrictive pericarditis, severe right heart failure, and restrictive cardiomyopathy. APASL criteria for NCPF or IPH are: 1. Moderate to massive splenomegaly should be present. Portal hypertension or varices or collaterals should be seen. There should be a patent portal vein, splenic vein, hepatic vein on a Doppler. There should be normal or near normal liver function, normal or near normal HVPG, and the liver histology shows no cirrhosis or liver injury. The pathology of NCPF is phlebosclerosis, periportal perisinusoidal fibrosis, aberrant vessels in the portal tract, preserved lobular architecture, and the main portal vein is dilated with thick sclerosed walls plus thrombosis in the medium and small branches, and this is called obliterative portal venopathy. EHPVO, this is a childhood disorder characterized by chronic blockage of the portal vein blood supply, leading to portal hypertension with well-preserved liver function. And as you can see in the picture, the obstruction is at this level in EHPVO, and it is at this level in NCPF. Etiology of EHPVO, it's said to be due to infections and especially umbilical vein sepsis as a neonate, and even abdominal wall infections, abdominal infections per se. Therefore, it's very important to take a history of any umbilical vein infection, umbilical infections in when the child was born. Infections: bacterial protozoal schistosomiasis, umbilical vein sepsis, drugs and toxins, arsenic, vinyl chloride, copper sulfate, methotrexate, azathioprine, and even vitamin A. Prothrombotic states, which are myeloproliferative disorders, protein CNS deficiencies, ACLA, it's anticardiolipin antibody syndrome, prothrombin gene mutation, immunological conditions like SLE, scleroderma, and celiac disease. Clinical features include bimodal age of presentation. That is, the child could present less than 3 years or more than 8 years. If it's less than 3 years, it's usually secondary to an umbilical vein catheterization and sepsis. If secondary to intra-abdominal infections or idiopathic, it usually starts from 8 years or early childhood. Then there is recurrent hematemesis, and this usually decreases after puberty as collaterals form. That's a natural history of this condition. Hypersplenism, it's usually asymptomatic and rarely presents with a bleed. Ascites, it's in 13 to 20%, usually after a bleeding episode, and leads to reduced liver function and decompensation later. Repeated left upper quadrant pain can occur due to perisplenitis and splenic infarcts. Moderate to massive splenomegaly, normal or shrunken liver, and no peripheral stigmata of liver disease. If jaundice occurs, it indicates usually portal biliopathy, in which case the ALP and GGT are elevated. And there can be growth failure in children. This is all in EHPVO. The pressures, both in NCPF and EHPVO, the ISP and the IVP are elevated, but not the IHP or the WHVP. So this indicates a pre-sinusoidal level of block. Indications for shunt surgery: refractory variceal bleed, symptomatic hypersplenism, severe reduction in platelets less than 10,000, refractory hepatic encephalopathy, HRS, HPS. Relative indications are portal biliopathy, symptomatic splenomegaly, in which the patient feels pain or there is early satiety because of the spleen pressing on the stomach. Preoperatively, we do a CT or an MR angiography to see the patency and the length of the LPV, which is also called the Rex vein. We see the SMV, the splenic vein, the LRV, and the size of any cavernomas. And if the Rex vein is patent, the procedure of choice would be a Rex shunt. If there's a patent Rex, then we do this MLPVB shunt or Rex shunt. And if that fails, we check for patency of splenic vein, LRV, left renal vein, and if it's of a good length, then we do a distal splenorenal shunt. And if it's not, we do a proximal renal splenal shunt or any other proximal shunts like mesocable shunt or portocable shunt. And of course, if this patent Rex is not present, we straight away go ahead for either proximal renal splenorenal shunt or distal one, depending on whether the SV, LRV are of good length and if they are patent. The treatment would be EVL, non-selective beta blockers, shunt surgeries. The treatment of EHPVO with portal biliopathy would be: if there are biliary symptoms like fever, pain, and jaundice, we might need to do an urgent ERCP and stent. And there could be a stone, a stricture present. We do the dilatation removal of the stone. We have to put a stent. If that fails, we do a shunt surgery, which would be hepatojejunostomy, choledochojejunostomy. The natural history and prognosis of NCPF: after timed surgery, long-term survival is nearly 100%. And with time, 20 to 30% develop liver parenchymal atrophy and then decompensation, or there's an HPS and they need a liver transplant. Congenital hepatic fibrosis is another differential diagnosis for a child or an adolescent that presents with recurrent hematemesis and normal liver function and a large spleen. This is rare. It's a fibropolycystic liver disease. It's characterized by periportal fibrosis, abnormal proliferation, and dilatation of intrahepatic bile duct. So it's a duct plate malformation. And there is preserved hepatic lobular architecture. This is usually associated with autosomal recessive polycystic kidney disease and Caroli disease. It's caused by mutation of the PKHD1 gene. It presents in childhood or early adolescence with portal hypertension, GI bleed, splenomegaly. The liver function is normal. There could even be recurrent cholangitis because of the abnormalities in the intrahepatic bile ducts. Ultrasound would show an enlarged spleen. There could be renal cystic disease. That gives you a clue as to the diagnosis. Liver biopsy is diagnostic, and you will find broad, fibrous portal tracts and irregular bile duct proliferation and preserved lobular architecture. The treatment is EVL or NSBB, and if recurrent, we can do a TIPS. And liver transplant is for recurrent cholangitis, decompensation, severe portal hypertension, and we do combined liver and kidney transplant if that is needed.